Shall we make a bit of a start? I can see Elizabeth on the line. Hi, Elizabeth, as well.
Let me just fill up 1 minute.
Okay. I have pressed record. Hello, Elizabeth. Nice to see you. You're on mute. We never tire of saying that, do we? We're on mute. So I'll make a start. I'm Jacqueline Smith. I'm part of the Leadership and Lifelong Learning team, and this is our opportunity to pick up on PCLC 6 and merge the second and the third sessions together with Debbie Sorkin, our National Director for Systems Leadership. What I'm going to do before I just quickly hand over is just let you know that I am recording the session so that we can, and we'll send you links for that later down the line. As always, would you mind microphone and your camera, turning your camera off so that we can get a better quality of delivery, which I shall do in a minute as well. You'll notice at the top, I'm not sure if you're familiar with Teams, you may be by now, but there is a little hand up that you can press the hand up button if you did want to ask a question as we're going through. If we hit some sessions that we want to ask a question, there's also a little chat box that you can, if you wanted to put something in, we can keep an eye on that as we're going through. And just very briefly, I'll be sending out the evaluations tomorrow, and then once we've got the evaluations back, I can send certificates out and all the links to the recording and everything at the end of the week. So welcome, Debbie, and thank you very much for giving us your time today.
Well, it's a pleasure, Jacqueline. Thank you very much. Thank you very much for inviting me. And thank you all very much for making the time, especially today, especially when everyone is so busy. Everyone has at least sort of 32 jobs and 53 meetings to be at. So thank you for doing this. Just by way of introduction, my name is Debbie Sorkin. I'm National Director of Systems Leadership at a place called the Leadership Centre, which is a charity. When we had an office, we were based in London, but we work all around the country, really helping people who are having to grapple with gnarly and difficult and complex issues like COVID, and to build and strengthen leadership capacity. And that's what I'm hoping to do this afternoon. So I'm not going to do the tricky bit, and I'm going to try and share my screen. We have a backup if this doesn't work, but just bear with me, please. Oops, desktop. Let's look. Right, can everyone see that? Is that okay?
Yeah, that's fine, Debbie, thank you.
Brilliant, thank you. What we're going to do, I hope, is have basically, after an introduction, a series of 4 conversations. I would really like this to be as interactive as possible. So I'm going to share a few slides and then bring the conversation back to plenary so we can have a chat, really about sort of 4 areas. The first is, if you're leading through COVID, you're probably leading in complexity. So knowing this and knowing how to adapt your leadership gives you a head start. There are some things to watch for and to notice if you're leading through COVID and in complexity, and mistakes to avoid, or watch while everyone else actually just falls straight into those traps. Then something on what you can actually do instead, using ideas and approaches that we know actually work, from research, from stories, from evaluation. We know these work when you're dealing with issues like leading through COVID, and some very practical tools in your armoury that you can just take away and use. We'll make, as Jacqueline says, we'll make all the slides available, so you don't need to scribble frantically. Much better to watch and listen and think. Think about, where have I seen this? What am I noticing? How does this apply to me? If you do have any questions, then please put them into the chat or raise your hand, and then Jacqueline or Vijay or someone will come back to me. So if that's okay with you, then we'll start. Why COVID means we need different kinds of leadership? Well, it's because our old styles of command and control really after a while are not going to help us. There's a place for command and control. There's a place, if you've got an emergency, everyone needs to know what to do. But when you're dealing with tricky and deep-seated issues, both in COVID and arising out of COVID, particularly, for example, around health inequalities, you need a different kind of leadership, away from command and control, away from adversarial styles. And I'm indebted to David Nabarro, who's a special envoy to the World Health Organization on COVID-19, for these nice little illustrations here. What I'm going to argue is that you need systems or adaptive leadership here, because this is about how you lead and work in these situations where you can have collaborative, distributed leadership. So it's leadership, it's not the leader at the top of your primary care network, your ICS, whatever else. This is about behaviours and actions at all levels. It's about influencing and how you work across boundaries, geographic, sector, professional. And it's about trust and why that is so important in helping you influence. So this is about hopefully changing maybe what you see or how you think and what you do, and changing others' perceptions, whether that's GPs or whether it's other stakeholders. And I want to emphasise that this is about achieving that without necessarily needing positional power, or from any level. So this is about how you can lead and achieve real change from any position. So why you do this and how you do this is by adapting your leadership to work in complex situations, knowing what you're dealing with. There is a man called Dave Snowden. Dave is an anthropologist by background, but works now in complexity thinking. And he describes things as being either simple or complicated or complex. So some of what you do will be simple. So you want to put your husband up for sale, as here. You put your husband up for sale on eBay, you sell your husband, he goes to live on a farm. That's simple. You do one thing and something else reliably happens. Some of what you do will be simple. You go into a room, you switch the light switch on, the light comes on. That's simple. Some of what you do will be complicated. So if you want to build a Nightingale hospital, then Colonel Ashley Boreham here on the left-hand side of this photo is your man. He has built field hospitals in Afghanistan and Iraq. He knows what to do. This is the situation where you do something, you follow a number of steps, often involving an expert like Colonel Boreham here, and then again, something reliably happens. Some of what you do will be complicated. A lot of medicine is like this. You do one thing, and then after a series of steps or interventions, something else happens. But some of what you do, and this is particularly the case leading through COVID, will be complex. It will be more difficult, more elusive, involving more people, more sort of shape-shifting, and crucially, less predictable, because the key thing here, the key difference is around predictability. When things are simple or complicated, there's a causal link. X will cause Y. When you're dealing with something complex, as quite often the case in COVID, there is no similar cause or effect. So you can't just pull a lever and expect something reliably to happen. So you have this sort of huge new initiative, you think it's going to make a huge difference, you launch it, and it's okay, but it's all a bit meh. You do something small and it has an impact over and above what you thought it would be. So X might lead to Y, but it might lead to nothing at all or something entirely different. You will only know after the event. You can't rely on this beforehand. So the only thing you can do is try something out and see what happens. And please note, this is the case irrespective of your seniority within a system. You could be operating absolutely at the front line or at operational level, and you could still be dealing with complex issues. And what Dave says is that people often end up in this orange diamond here, where people insist on treating a complex issue as simple or complicated. If you are ever stuck in a load of really, really endless meetings, getting nowhere, that is probably what is happening. So how do you know if you're dealing with complexity? Well, look for these kinds of situations, and hello, here we are. New. Well, yes, absolutely. Over the past 10 months, we have all had to deal with a great deal that is new. You've got things that are suboptimal that you just normalise and you have workarounds for. So if you've got terrible IT, you've got terrible data sharing processes and you just normalise them, that's complex. If you're not sure what the issue actually is that you're supposed to be dealing with, that's complex. If you're trying to knit together lots and lots of different people and organisations and lots of sectors to deal with deep-seated issues, say around health inequalities, well, welcome to complexity. If you're working with local councillors or national government, this is you. And if it feels like no one is in charge, that's complex as well. So a lot of your work to lead through COVID will be about dealing with complexity. So I said this will be a series of conversations. Really what I'd just like is to have a conversation with you, for you just to think about what is complex about what you're working with or seeing right now, what actually happens here. And it can be directly around COVID or a knock-on effect. So I'm going to stop sharing my slides for the moment and I'm going to come back to you. See if this works. Ooh.
So just some of the comments in the chat,
Yep.
Debbie.
Yeah.
Sometimes a simple can be complex with starting with a new approach. Example of the centralized delivery of the shielding message to individual patients.
Yes.
Caused a lot of distress. Yeah.
Yes, and I think Rob, actually that's a really interesting example, because it's that classic thing of treating something that is complex as simple. All we need to do is to send out one message and somehow somebody else will pick up the pieces and make this work.
Absolutely.
And you end up thinking, I don't know what to do here. I don't know what to do for the best. And then you end up making decisions on the hoof. So I think that's a really good example. Do you want to talk about that a bit more? And you can pop your camera on as well. So
yeah. I mean, obviously I've been.
Rob?
Yeah, no, I've been. Yeah, I've been working as a salary GP in a practice that obviously was implementing some of the COVID changes from day one, in a big practice where the workforce was a bit under pressure, so seeing quite a lot of dynamics. But I think that one, particularly in the early days, illustrated what you've just said, is that we were getting directives coming out almost daily from central, either from Public Health England or the government, even in the media. Patients were hearing and listening to information, and we were then being asked to then, with our own databases, give the appropriate advice and also include supportive communication for those who were in work. And that's where the individual, as in the patient, was central to the whole process, but almost had been forgotten.
Yeah, absolutely.
And in purely in sort of, if you go down the route of patient-centered stuff and how this individual is going to access what they need and what their issues are, it just felt very clunky and messy.
Yeah.
So and did cause a lot of challenge.
Yeah.
So across all, both clinicians, but also right across in the primary care setting, from a receptionist through to admin, through to doctors, nurses, the whole team.
Yeah. That sounds classic. Dressing up something complex as something simple, and just realizing that. Sorry, Mark, I think you want to come in.
Yeah, I think typically that's what we're dealing with now, because of the COVID response in primary care, which there's been some adapted to some level successfully. Then we have an additional lockdown that we're trying to make sense of the impact. I think what I would say is adding the COVID vaccine being seen as a simple process by the Department of Health. For me, that's a typical example. There's a complex situation that is not yet settled. There is just trying to adapt. And you say, oh no, if you just vaccinate these people, get people to get the COVID vaccine, just set them in a line, do 90 a week, including Saturday, Sunday. Nobody's looking at, we've already had really tired, almost burnt out staff, and kind of lots of, you're just adding. So people are seeing the vaccination as a simple process, as the flu had been for some years, while it's not.
Yes, and that's a lovely example actually of something I'm going to come on to talk about, which is reverting to default behaviours. Going back to what you're used to. There is something I call Department of Health-itis, which is treating something as completed by announcing it and imagining that that's the same thing. And this has been, I remember when I was working with the Department of Health, this was very, very common. And it's partly wishful thinking, it's partly, you can understand why it's happened, but it's absolutely what you're describing, Mark. Yes. Yeah. Anyone else want to come in? Well, just looking for a hand, or just to if you want to take your mute off and just talk, please do.
I was reflecting the same way as Mark was, that they've made that same classical mistake of thinking this vaccination program is going to be complicated, but it's not. It's complex. Yeah. Because we haven't got the information and regulations. All that stuff is just not available to us yet. No. And they've oversimplified it again. Yes. And that's why it will fall.
Yeah, absolutely. And it'd be so much more difficult than it might have been if actually people had applied complexity from the start.
Yeah. I was on perhaps with others, I was on a primary care call on Thursday, which we have. There were 1,000 questions in the chat box from GPs. That just tells you with a complex issue.
Yeah, absolutely, and all quietly brushed to one side.
There were no more answered.
No more answered. And there's something about modelling leadership behaviours and what that tells you as well. That's beautiful. That's absolutely beautiful. Sorry. I'm going to go to Romy and then back to Rob. Romy, sorry, you're on mute. The inevitable.
Hi there. So I really just wanted to add to what Vijay was saying. So I work for a CCG and I'm doing this collaboration with my practices. And this COVID vaccination, we're being asked a lot of questions to which we don't actually have the answers because the service specification is not out yet. So normally the people who can respond to their queries, which is us, we don't have the information ourselves, and we are almost as working as in the dark as practices are, but we are trying to deliver this this program, which is quite massive, and a lot of the public don't know about it. So I'm going to our patient group tomorrow, and I've actually asked NHS England, what can I say, what am I not allowed to say at this point? And it's just making the whole delivery of the process so complex and complicated. And we are in kind of, almost month 8 of this pandemic, and everyone, commissioners, providers across the system are kind of burnt out. you know, there really is, you know, genuine burnout and a lot more irritability than when it hit us in April. I think in April we were all, okay, guys, we you know, we know this has happened. It was all hands to deck. But I just feel that pushback is now more there.
Yeah,
across the system.
Yeah, I think doing a talk earlier and using an analogy from the military, there's a difference between being tired and being fatigued.
Yes.
And what people are at the moment is just it's this tiredness that's been allowed to build up, so that you get to that burned out stage. Yeah. Yes, I have a lot of sympathy, Romy, believe me.
You have to laugh, otherwise you're going to cry. So that's my motto.
Yes, be careful. Rob.
Yeah, it was just a bit more of just a follow-on, really, in relation to the response about the vaccination and the willingness, and you know, following on from what Romy said about this simplistic. Oh, of course, primary care will do it.
Yes.
And with just no real insight into the implications of yet another directive, where actually can we, and coming back to your words in your initial few slides about trusting the system to support us in delivering it effectively, and not actually looking at the problem in an honest and open and realistic way about delivery. And you know, and there are places, and I think the other thing is it's about the other phrase that irritates me, and it would irritate me even more if I was a nurse or a healthcare assistant, is GPs will do all the immunising.
Yes.
Again, it's just such poor communication of, and it is about the communication of it. So yeah.
Yes, and in fact we'll come on to that in a bit. So hold that thought, because I want to go on now to what to watch for when you're working in complexity, and what you've described is a lot of what I'm going to be talking about. So just bear with. Let's look. Lovely. Two things. If things are difficult and they keep on being difficult, first of all, you know, this is hard work, so give yourselves a break and support each other. You know, I've always seen these leadership collaboratives as real kind of communities of practice, so I'd encourage you all to just keep connected with each other. And the other thing is that people will try and push back in some way, will try and resist in some way. There are a couple of South American evolutionary biologists who've likened a system to a simple animal, like an amoeba. So this here on the left is Barry, shortly to be Barry and Larry, amoeba. And as you can see, Barry isn't particularly bright, but he can feed, he can move about, he can, as you can see, reproduce. And crucially, like any system, Barry is adapted to his environment. A system is adapted to its environment. So Romy, you come along and say, I've got some really great ideas here, better patient care, lower costs, better connections through the primary care network and the ICS will help us with COVID vaccinations. The natural response of the system may not be, that's a fantastic idea, let's do that straight away. The natural response of the system may be to kill it, because it's seen as a threat, and a threat not necessarily of change, but of loss. And yes, possibly loss of job as stark as that, but often about the stuff in people's heads. So loss of perceived professional status, loss of locus, loss of place in the system, loss of certainty, loss of stability, loss of familiar ways of doing things. And if we think about the extent of what people have lost, yes, in the context of the NHS, but much more broadly, that might be why you are getting pushback. So if this is happening, or before you want to introduce change. It might be worthwhile trying to go for a virtual coffee with somebody, and who knows, after the 2nd of December, a real coffee with somebody, and try and work out in advance what the stuff going on in people's heads might be and how you might reassure people. You will probably get change eventually. If the system is held perturbed for sufficient time, it adapts to the new conditions. But you can save yourselves an awful lot of time and angst by actually thinking about this in advance, particularly if we're working in a COVID world, which has not just sort of flattened all our ideas of what we could do, of how society functioned, but gives us, even at the present time, no clear route forward as to how we're really going to get out of this. This painting here, it's by Andrew Wyeth. It's called Christina's World, and I use it a lot because I think it really beautifully illustrates that sense of, you know, how do we get back to what is familiar to us. When you get resistance, it will come not in single spies but in battalions. There are lots of different ways that people will avoid real work and try and sort of get you not to engage with complexity. And the key thing is not to just file these under R for random, but to notice them and see them for what they are. You get a lot of deflection tactics, for instance, a lot of whataboutery. So the Daily Star has been having a blinding COVID pandemic, great headlines. And this is back in June, July time. It was talking about the Black Lives Matter movement, and it somehow made it into something about statues. How hilarious. No, Black Lives Matter is not about statues. Don't be deflected. There'll be an almost kind of instinctive primal pull with some people to get back to default behaviours. You know, we must get back to normal. You know, GPs will deliver the vaccine. You know, what people assume normal is, or things like we'll have another restructuring. It's a great default behaviour. Honestly, it will take people's eyes off the prize for months on end. Obscure language. This is a great one in the NHS. You know, if you've ever been in one of those meetings when you sat there and you thought, I thought I spoke English, I'm not sure I understand any of this, but everybody's very quiet. And then everybody goes out of the meeting and thinks, I have no idea what that was about. Worth pushing back if you can on this. There is a great American writer called Meg Wheatley, and she describes the role of leadership as being about creating islands of sanity. Well, this is one of those islands of sanity. And be very tactical. You know, don't do this on your own, because you know, you'll see every pair of eyes on a team meeting swiveling towards you. So do this in groups, hunt in packs. Somebody says, could you please explain that? And then somebody else comes in right behind them and says, yes, please, I would find that really helpful. But get these islands of sanity if you can. I give you Sorkin's law. If it sounds like guff, it probably is. Push back against obscure language. It's actually giving you a really clear message about unwillingness to engage in complexity. Other things, doing the wrong thing busily. Some people make a career out of meetings and back-to-back meetings at the moment, or endlessly delayed meetings. Love to meet with you, Rob. Is 3 months' time all right? Misuse of governance. This can be like domestos. It can kill all ideas dead if applied at the wrong time. So I'm a Ned. I would never say don't have good governance. But what I mean is, if you put forward an idea and that someone says, that's really interesting, can you tell me the terms of reference? Can we have a focus, can we have a steering group on that? That's the kind of thing. Denying a problem exists or shooting the messenger. You don't need to shoot very many messengers before everybody gets the message. So notice these. This is not an exhaustive list, but many of these are things that you will come into if you are working in complexity and other people don't want to. And when things are complex, as they are with COVID, people tend to jump to familiar ways of working, familiar responses. These are all things to avoid if you can. The first one is try not to jump to solutions. And this is really hard. This is really, really hard. You can't always do it. But if you can, ask questions rather than leaping to the immediate solution, because the immediate solution in a complex situation is likely to be wrong. And also, if you ask questions, you can sometimes get other people to change their own minds so that you don't actually have to. Really worth asking as many questions as you can before actually deciding what your next step should be. So try not to jump to solutions. Try to avoid the blame game. It's really tempting. We find it so cathartic in this country. You could argue there's been a giant blame game being passed around COVID, you know, particularly around public health. You know, I didn't see many people from Public Health England in the birthday honours list, all about, you know, who you can blame. Try to avoid this. This is one of my favourite slides of all time. This is from a man called Keith Grint at Warwick University. You've made a mistake. Will it show? No, bury it. Problem avoided. You've made a mistake. Will it show? Yes. Can you hide it? Yes. Conceal it before someone else finds out. Problem avoided. You've made a mistake. Will it show? Yes. Can you hide it? No. Can you blame someone else? Yes. Get in first with your version of events. Problem avoided. Note, avoided. Not highlighted, not identified, not managed, not thought about or considered. And eventually, if you avoid the problems, as we all know, they come back to bite you, and some of them have very big bites. So it might not be possible in the whole of the system, but anything you can do within your immediate team and system to have a learning culture, so that if something goes wrong, you learn from it, and you treat it as an issue rather than avoiding it. That will actually be hugely, hugely beneficial in a complex situation. The other thing is trying not to pretend everything is a success. There's a lovely book published about a decade ago now by a man called David Collinson called Prozac Leadership. This is where everything has to be a success. If you think back to the old success regimes, again, it becomes not the done thing to raise problems. And the people who tend to believe this are the people at the top of organisations or sectors, and they are constantly surprised when they are tripped up by reality. And if the phrase world beating is occurring to you at this stage, that is no accident. The last thing not to do is to put things in the wrong box. So this is taken from Ralph Stacey, the sort of management and complexity writer. If you've got if you're really certain what it is you want to do, and if you're all pretty much agreed, then you can put things in the blue box, the box of ordinary management, you know, good people management, good process management. You know what you're looking for in terms of outcomes, and you can provide really clear direction. When neither of those things obtains, then say yes to the mess. Use systems leadership approaches that we're going to come on and talk about next. You actually amplify the differences and the concerns. You change the way that people think about, in other words, reframe the issues that are there. You have the conversations, you ask the questions. There is a real tendency at senior level, as we've already discussed, to put yellow circle issues into the blue box. And this is where you find yourself with 1,000 questions with no answers, or sitting in meetings going round and round the same issues. So just to recap, when you're leading in COVID, you are most likely to be leading in complexity. That is, you'll have new situations, you'll have situations which have a political bent of one kind or another. You'll have recalcitrant issues which are suboptimal but which you normalise. You'll be dealing with lots and lots of different people and trying to fit them together to go in a particular direction. And where that happens and where things are complex and difficult, you are likely to get pushback of some kind, quite often because people don't fear change, but they do fear loss. And people have lost an awful lot and fear losing a lot more. And people will tend to push back in various ways. They'll go to default behaviours, they'll use obscure language, they'll shoot messengers, the choice is yours. And when you're in that situation, one of the best things you can do is not follow common responses, however tempting they are. So not jumping to solutions, not playing the blame game, not putting things in the blue box, and not pretending everything is wonderful. So I now want to come back to us to think about what types of pushback are you seeing in relation to leading through COVID? Some of it is just, we've seen flat refusal to engage with questions. Some of it is saying, we basically back to business as usual. Oh, the GPs will deliver immunisation. But I suspect there are other types of pushback and resistance that you've seen as well, whether it's obscure language or shooting messengers or misusing governance or going for whataboutery. I suspect a lot of them are there. So I'm just going to shut my screen and come back to you. Right. So, anyone to start, but any ideas on the kinds of resistance, the kinds of pushback that you're seeing? Rob, I'm going to start with you. Because you have your hand up.
Oh, do I? Oh, crikey.
Yes. Oh,
okay.
right.
Right, that'll teach me.
Yes.
Yeah, no, I think a lot of them resonate, even on a simple level, in terms of where I've been working, looking at workload and work delivery, and the leadership has been a combination where one's reflected and thought, actually there has been some listening, but when you boil down to it, the listening and the tactics have been a bit of look what we've managed to do. Prozac and actually looking at want to get in one or two quick solutions rather than really wanting to go and explore the wider issue. And what the aim might be for the wider issue in what you might achieve, and particularly in relation to the workforce, which I'm particularly interested in, is about how, and I do appraisal about how doctors and other clinicians are feeling and being listened to within the system. Now that's in primary care, but it may be secondary care as well. And I think there is a mechanism of listening, but it isn't real listening. And therefore, what tends to happen, and in my question, I guess, which I get stuck with, is it seems when a system is under pressure that the option of going for quick solutions and not really addressing the problem is in a way what some in leadership have the capacity to do, but don't feel they may have the capacity to take that more difficult step of just having a look wider. It feels almost like an indulgence, maybe, or we haven't got time to do that. All that kind of.
Yes.
Yeah. So and that to me is quite across the system is kind of quite apparent to me a lot in the NHS, really.
So we have to do something, therefore we have to jump. And there's a difference, I think, the difference is when you've got a real emergency, fine to command and control. Absolutely everybody needs to know what they're going to do. But if you keep on with command and control, that I think is where the issues stop being so amenable to emergency solutions, and eventually people do get burnt out because it's hard being on call, on emergency with that level of adrenaline all the time.
And I think and I think in the dynamic which at times I think things can improve, and there's a lot of work to be done on both sides, but not using the but word, but and CCGs and primary care and how they can work collaboratively is where, back to Romy's point, where she's going into a meeting tomorrow where actually she hasn't got all the answers, but actually how she delivers that meeting, to me, can be more meaningful in how she delivers that in an open way, rather than what sometimes happens, because they're put under pressure as well to actually, with other things, is do this. Here's your time scale. This is what you need to measure. This is what you need to deliver, whether you believe it or not. And they're given no time also to engage with us in the system. So it's a very difficult dynamic, and we need to see how we could improve that.
Yeah, and maybe just push back a bit, sort of creating that kind of island of sanity, not as individuals, but as a group. Because sometimes if you go as a group, it's surprising how much room for manoeuvre you have.
But it's working out, I suppose, from my point of view, where we are is, I suppose it's working out, in a sense, is who your allies are, because we are little tribes, unfortunately, which is not helpful. Whereas we're in it, we're all, if we go back to the fundamentals, we're all in it a lot. Well, the majority of it are in it to deliver good patient care. And I know it's a phrase, but actually that's why I go to work. That's why some of the people in the CCG go to work. They want to make a difference. It's not just, and therefore, how do we do that? Anyway, I'm going to stop now.
That's all right.
Thank you.
No, thank you, and keep hold of that little tribes, because we're going to come on and talk about that. Who else would like to come in, especially people who haven't so far? Ooh. Very quiet. Yes, thank you, Romy. Yes.
Okay, sorry, I know I've already spoken, but as none of my other colleagues are coming forward, I just wanted to add, so I think we've had lots of guidance and advice from above, so from national NHS England and regional NHS England teams, and whereas in the start of the pandemic it was kind of little bit more accepted, I think the further it's gone along, but the guidance and the advice is still coming from above, I think there has been pushback to that. I keep telling my NHS England colleagues that, when the pandemic hit in April, we promised practices, just go and get what you need, we will pay for it. And I said, and this is August and I'm still asking you for the funding so we can on to practices. I said, you have to accept at some point, they're going to go, do you know what, enough, I'm not doing anything now. So I think the longer it goes, if you can't keep up everything you promised from day one, the situation gets worse. It's like I think, all the guidance from above hasn't really helped, because it's just told them what they need to do, but not supported them in doing it. So they're talking about 150 million national funding coming down to deliver the COVID vaccination programme. Our GPs and PCNCDs are very clear that it will support them. But when I've seen the information from NHS England, it's very clear what we can spend that money on, and it isn't necessarily linked to the COVID vaccine programme. So what they're saying and what they're actually delivering are kind of two different messages.
Absolutely, and that is where you lose trust.
Yes,
ultimately. Going to come on to, and why trust is so vital. It's absolutely fundamental when you're trying to lead in a system, and particularly at the moment, trying to find a way through on COVID. So yes. Now hang on to that example. Thank you. Mark.
Yeah, I think when you were mentioning this, I was just, because these are experiences, asking for more data, make a business case. I was just smiling, because even at the micro level, I remember, and this got to do with the flu vaccination, not even this one. So in our group of practices, we planned to do the flu campaign this year. This was way back. Initially, we're going to be central. Then they said, each branch will have to do it according to what they want. And one of our nurses was well ahead of the game. She had gone to a local charity, hired the hall. She says something like £200. We're going to get like 40 quid to get bags. That will do all the social distancing and sort it out. And we said, fine. It was something less than £300 in the scale of things. Went to them and said, oh, that's it. We've got our plan sorted out.
Yeah.
Actually, we just need £300. This
Yeah.
is what. And in the scale of, you know,
That's
something
nothing.
about
Yeah.
30.
Yeah.
And the response was, yeah, okay, you need to go back and do a business case and submit a business case for it.
Yes.
And come back. Or sometimes she's asking for more data. And I think it just resonates, really. Sometimes it's just frustrating, you know, and I'll always remember, actually, it's Benny Dembitsa, you know, who's an economist, who was more Nobel Prize winner with international state. I remember him saying, actually, listen to say, sometimes the solution is so clear that it is blinding us to be able to see it. You know?
Yeah. And sometimes I think, going on from that, it's not the report, it's the act of reporting.
Yes.
The kind of cargo cult mentality. As long as you have reported, it almost doesn't matter what's in the report. You know, you could be reporting the 315 results from Kempton and it will make no difference as long as it's, you know, topped and tailed in that reporting style. Incidentally, I know one person in the NHS who swears that he has delivered the same report, only with a different date. For this was last year. He did it for 10 out of the 12 months, and nobody ever came back to him to say, "Hey, what's wrong with this?" So I'm not making any recommendations here. I'm just saying that sometimes it's not about the report itself. It's a power thing, and it's also a work avoidance thing, I think. Any more before we go on? Right, in that case, I'm going to go on from what not to do to what I think you can actually do in these situations, and I think it's a lot. So. What you can do, I think, is to use systems, leadership, ideas and approaches to help you find your way in leading through COVID. I sometimes call this the God of small things, because instead of saying, oh, we need to have this massive solution now, we need to do something that's transformative, we need to make these huge changes. This is about small, doable, practical actions that over time accumulate into something bigger. So see it as something that you can do. This is about leadership, not about being the leader. So it's about collaborative leadership that is distributed geographically and at different levels, shown through actions and behaviours, not through by dint of being the leader at the top of an organisation or a system. And actually, if it's complex, then it needs to be distributed, because no one person can be in charge. It's about networks of people, so anybody can come into these, of people in different places at different levels who come together on the basis of a common purpose. Take nothing else away from this afternoon. If you're going to lead through COVID, common purpose really helps. Really clear about what it is that you want to do, what other people want to do, where the overlap in that Venn diagram is, and why you want to do it. So why you want to do it, not why NHS England an improvement, not why somebody else wants you to do it. What is it that you want to do? Giving yourself agency and knowing what the pressure points are as well. So if somebody has a problem and they can't do something, they're not being unreasonable, it's just because of where they are. Nice way to get to common purpose is to use an open question. What do we want life to be like for people in our place? Who the people are is up to you. It could be older people, it could be teenagers with type 2 diabetes, it could be working age adults. Doesn't matter who the people are as long as they matter to you. Just think, what do we want people's experience to be of primary care in our place, in our system? You'll always get to the money, incidentally. You always get to the money eventually. But this gives you a way of parking that question just for a bit, and of getting some different answers, and of thinking who else needs to be in the room to actually help us get to a common purpose here. It's about the relationships that you have. This is key when you're leading in complexity and leading through COVID. The relationships that you have or you can build, and the trust. We talked about trust earlier. The trust that you can thereby engender, and the influence that you can thereby have at all levels of the system. There's a nice line, systems move at the speed of trust. That was a former director of public health who came up with that one. It's not mine, but it's absolutely true. And as I said before, it's about taking small steps in changing situations. Take a couple of steps, see what your next move should be, and then decide how you should move, rather than saying, this is our 3-year plan. And it's about, therefore, networks and what I call coalitions of the willing. Rob earlier was talking about little tribes. Maybe another way to see them is as little coalitions, groups of people who want the same thing, who want such life to be better for their patients. Coalitions of the willing who are willing to actually do something and work together. And just to mention, again, just going back to the idea of this is not heroic leadership. This is Greg Fell, Director of Public Health in Sheffield, but noting this is about, if you're leading through COVID, this is about collaborative leadership. And there are practical things that really help here. In my own organisation a few years ago, we commissioned national and international research into the kinds of behaviours that work when you're leading in complexity and when you're leading in a system. And this is a quote from the summary of that research. And I've just put, sorry, I've just put the link on the left-hand side there. Sometimes describe this as being about leadership for introverts. So not about being the leader, hugely charismatic, leading from the front. This is about being much more thoughtful, more reflective, working in the background and supporting and enabling other people. And there are ways of behaving that really work here. Find to ground things in your values, for instance. So I'm not doing this because it's a job. I'm doing this because actually I think this is the right thing to do. If you've got your values and your common purpose, that will see you through the long haul. And particularly because COVID, despite the vaccines, is going to be a long haul. So that will see you through changes in any numbers of secretaries of state, of different guidance from NHS England, of people in the regions, or people in your own primary care networks. Ground things in your values. This is why I'm doing this work, doing this for patients, and I'm here for the long haul. So that is going to be my guiding principle, irrespective of the initiatives coming down the line over the long haul. It's worth getting off the dance floor and onto the balcony, standing back a bit. It's great if you're on the dance floor, you can dance with all sorts of different people, but if you get onto the balcony, you get a wider perspective as to what's going on. So who's dancing with whom? Who isn't dancing? Who's standing around the walls? Who's in the kitchen doing the washing up? Who's outside not being let in by the bouncers? And we'll stop this metaphor in a moment. But you see what I mean? You can actually think about who else do I need to contact? Who else do I need to put together? Worth having a wider perspective. And it's about supporting and enabling other people, making sense of things for people, just enough clarity for now, so that people can get to the next stage and not feeling you've got to do it all yourself. Others can lead for you. Really worth trying these things out. and worth trying stuff out wherever you are in the system. You don't necessarily need positional power. This is Richard Seale's idea of leading from the middle out. People leading in the middle are in a great position to actually get stuff done, despite being pressured from the top and from below. You're the people with the connections. You're the people who actually know how to make the system work. So you can have influence wherever you are. It's not necessarily dependent on positional power. And you can have some very different conversations if you actually adopt these approaches. These are two examples from work that was done about 4 or 5 years ago now, but really changed ways of in which homeless people engage with mental health, so that you had improvements in discharges from hospitals and better joint working. And in Calderdale, you had better levels of physical activity because the local health and wellbeing board and public health actually involved the schoolgirls in deciding what the activities should be. So just to recap, if you're leading through COVID, systems leadership behaviours can really help you here. These are about doing small things, working in small ways, leading collaboratively. That is, having distributed leadership on the basis of networks of people, coalitions of the willing, coming together on the basis of common purpose, using relationships and trust and influence, and taking small steps that over time can build into something bigger. And you can practice leadership in a whole variety of ways. You can ground things in your values, you can make sense of things for other people. This is about enabling and supporting other people. You can stand back a bit, get onto the balcony, take a wider view, and you can think about who else can lead as well. So I'm now going to again come back to you for any thoughts, comments, questions, things that are kind of occurring to you about the kinds of leadership that this implies. Right. We got Mark, you've got your hand up. Is that a legacy hand, or is that a new one that's gone? What do people think? Is this making sense to you? Or can you see examples of it in your own practice or in the practice of other people?
I'll chip in then if no one's
Thank you.
VJ.
Yes.
It's always, you know, people do things for people, and it's always worth remembering that, not for organizations. And the other phrase I always remember is that relationships are the currency of leadership. And it's through relationships that you get trust. And then that other phrase you said as well, systems only move at the speed of trust. So it just comes back down together. And if you don't do that, you're not going to get influence or do any of that. So it completely resonates, you know, in our daily working. This is how we get things done, you know.
Absolutely, and showing people that it is through relationships. It's not through diktat that you're actually going to get things done at the end of the day. Thank you, Romy. I'm going to come to you and then to Rob.
So I just wanted to add, I don't know if this is leadership, but one of the things that we implemented back in April was that we sort of told our practices that, guys, there's a lot going on, you know, times we've never faced before. So we'll start a weekly practice / CCG call. And it started off as something, you know, that we didn't really have an agenda for, and we would just open up the floor at 1 o'clock on a Tuesdays every week, and, you know, practices would bring to us all their queries and concerns that they were facing. So not quite leadership, but I think it was very, it was very collaborative. And I think it just made them feel that they had a time and a space to actually discuss what their issues were. It was very, very popular. I'd say about 95% of practices were attending.
Yeah.
During the summer periods, I did go back to them and say, so, you know, it has gone down a little bit. Shall we close it? But the mass view of practices was no, it's really helpful. So what we did was we did it once every 2 weeks.
Yep.
And 8 months later, we are still continuing once every 2 weeks. And, you know, I make sure that somebody from my team is always there to chair the meeting and to go through the different topics. You know, we've got an agenda nowadays. We call different people into it depending on what practices come back to us during the week or what the kind of hot topics are. We had a few practices that had to shut due to COVID outbreaks amongst their staff. So, you know, we use that forum to kind of bring in public health colleagues from the councils, but it's just an open space for them to have that discussion and to raise their concerns. It's not minuted. It's not. It doesn't form part of our governance structure, so they can be as open and honest as they want to be, and they know they won't be reported back to NHSE. I think that's, you know, one of the main things. But I think it's a very open and friendly and collaborative approach. And even though that's not, you know, doesn't tick all the leadership boxes, it's definitely worked at this point in time.
Absolutely. And it is about the relationships and the trust that people have, because they can feel they can have honest conversations. Otherwise, you know, you're just sitting around one of those vast tables, you know, they basically either sort of speaking or doing your emails, you know, it's that kind of meeting, or you can have something where people are really engaged. Thank you. Yes, more power to your elbow. Thank you. Rob.
Yeah, it's just building on really what VJ said and what Romy says, which is resonating, and I think it's, for me, it's sometimes, if you look at teams or where you're needing to develop some kind of cohesion, you almost need to not start with an agenda. Almost, it's a connectedness thing going on about, and VJ was touching on about trust, and it's, but how is it for you at the moment? How are you? What would? So it's a more open, it's just a more open forum, a bit like Romy was saying, rather than there has to be an output. To get that level of cohesion, where then you can then perhaps move into the areas that are the challenge, and sometimes again that process can be missed out.
And don't, because it's vital. It's absolutely vital. If you don't have it, you're just, you know how you can be in these meetings and you just feel, I don't know what this is, we've nominally got an agenda, we've nominally got things to do, but it's just not gelling, it's not connecting, it's just kind of words. So yes, absolutely, don't miss that stage out. It's absolutely, it's real work. It's as much real work as any agenda. So no, thank you for that. Anyone else, any comments before I go back and talk about what we can do more for any more? If not, what I'm going to finish with are some practical tools that you can take away and use. So tools really in your armoury, and we'll come on to Fluffy the cat in a minute. But I want to start elsewhere. There will always be good reasons not to do something or to avoid real work. You know, history will get in the way, culture will get in the way. If you have toxic relationships in your place, you know, it might just be the wrong time and the wrong place and the wrong people. You might need to choose your battles. Helen Bevan of NHS Horizons has a lovely Native American saying, if your horse is dead, get off it. You know, sometimes your horse is just dead. No amount of defibrillation is going to bring that horse back. Sometimes it's just the wrong time to do something, and you might need to want to think about, actually, what else can I do in these situations? But that doesn't mean that you can't do anything. It doesn't matter where you start. You don't need to have everybody lined up behind you. You just need your coalition of the willing to start with, and then let other people join you. You only get change by taking action. There is a man called Myron Rogers, who is a writer on leadership and complexity, and he has some maxims that I think everyone should just paste to the wall. So people own what they create. You're much more likely to get and keep change if people have had a hand in actually creating it and co-designing it, rather than expecting it just to kind of arrive fully formed by diktat from NHS England or improvement. It is about real work. It's not about a strategy or a plan. It's about doing real work on the ground with real people, and the people that do that work will be the ones making the change. Start anywhere, follow it everywhere, and keep making the connections across the system. And let's try and do something different at times, because if we keep thinking in the same way and doing the same things, we should not be surprised if we keep getting the same outcomes. Talked at the start about amplifying what works and shutting down what doesn't. This is an example from spring of this year, and it was about the practice of putting patients on their fronts rather than on their backs. This was not a randomized control trial. This was something that people found worked in a complex situation. They amplified it, and it spread very quickly. You know, there's only a couple of weeks between these two articles. So it's worth thinking about what is your ask to the people around you, GPs, line managers, federations, about permission just to amplify what works without needing, as Mark was saying, a business case. Tools in your armoury to do this. First of all, something that's really useful for getting to common purpose, it's called empathy mapping. So you're in a meeting with a group of other people, instead of just going down the agenda, or instead of thinking I am a representative of my organisation, you get people to take off their organisational or their sector hats. You put a person, a patient in the middle, and you ask people around the table to think what it's like to be in their shoes, what it is like to be on the receiving end of the system. What do these people see? What do they hear? What do they think and feel? What's really important to them? What really influences them? What matters to them? And then what do they do and expect? And this can be revelatory for people. If you show people how the system as a whole, so not them individually, not their individual organisation, how the system as a whole impacts those people, it's a great way of getting people to think about what is it that we as a system want to do and why do we want to do it. So really worthwhile having this as a tool in your armoury. The other thing is to think about who you might want to influence. These are a couple of techniques derived from community organising. Rich pictures. Your rich picture is not a work of art. You do not need to be an artist to do this. All you're doing here is mapping out the system as it looks to you. So you can have stick figures, you can have symbols of any kind. We've had sharks in the past, we've had Darth Vader, we've had sunshine, we've had storm clouds. But it's really worth having a go at this. Maybe sometimes doing it in pairs and then comparing and getting your oppo to look at your rich picture, and then you can look at theirs. It can be very revealing about, actually, I need to be targeting these people, irrespective of what it says on any official organogram. And then you can use actor mapping to think about who your supporters are, who really shares your values, who might be in competition as well at times, who the opposition is, and incidentally the opposition might be in your own organisation. It's really worth giving these a go and just comparing and contrasting, because then you can think about who do I really want to influence and who do I really want to target. Really important tool in your armoury. Worst thing ever to say to a British person, tell me something about yourself. This is, in a sense, tell me something about yourself, but not in terms of anecdote, not in terms of I met this bloke down a pub. This is about narrative as part of your leadership role. And it's especially important during our experience of COVID, where we're getting very, very mixed and confusing messages. This is not about story for its own sake. This is stories that get other people to join with you in action. So it's really important if you want to influence other people. And this is just, you know, a whistle-stop tour around this now. But if the collaborative ever puts on any events around public narrative, or you see them through primary care or through NHS England and Improvement, get on them, because this is a skill. It's not a script, it's not a performance. You don't need to be an extrovert to do this, but it really, really helps with influence. And the way it's structured is in 3 ways. So you start off with story of self. This is why I am doing this work. This is why this work matters to me. And then you link it to your audience, and this is why this matters to you. So my story is your story. We all think this issue is important for these reasons. We are connected here. And then crucially, you move into story of now. We all think this. This is therefore why we need to take this action now. If we don't take it, bad things will happen. So it's not just story, it's story to an end, story with a purpose. It's a skill, it benefits from practice, it's really worth thinking about this and adding this to your tools in your armoury. And especially if you want to build trust, as we were talking about before, to have these clear narratives. If you don't, people will take their own conclusions and act accordingly. And I've taken these 2 examples here. Frankly, I could have chosen from any number of examples over the last 3 to 4 months. And I'm not going to play this now, but if you want to see public narrative in action, watch Barack Obama at the Democratic National Convention in 2004. Doesn't he look young? First 6 minutes. It absolutely does. Story of self, story of us, story of now. Public narrative was the invention of a man called Marshall Gantz, who was a community organizer, who started out as a community organizer in Chicago, and he worked with Barack Obama on this. Really worth having a look at this. And you can tailor your stories to different audiences. Think about who your audience is. So if you've got people who just like to get on with it or who like to experiment, then you can think about how do I tailor that story towards action. If you've got the theorists, then when you're talking about story of self and story of us, you can refer to the evidence that actually backs it up. It's worth thinking about both your audiences and the stories you want to tell, the narratives you want to tell in advance. So last thing I want to talk about is framing and reframing. Could you please turn your mutes off and turn your microphones on? First of all, I'm going to take a bit of a risk here because some of my younger audiences have not recognised this actual sitcom. So could you shout out, please, if you know what this sitcom is? What's it called?
Thank you.
Thank you. Oh, that's such a relief. That's honestly, that's such a relief. Right. If I say to you, stupid boy, which character in this photo am I referring to?
Ian, whatever his name is. Pike, that's it.
Yeah. And you know that because you have been told that pretty much every week for 40 years. Dad's Army was first on when? Early 70s, was it? Mid-70s?
Late 60s.
Yes.
Yeah.
Back to then. And has been on British TV pretty much non-stop since then. It's still on, you know, on a Saturday evening as a filler. So you have been getting that message about Pike all your lives, effectively. And in some cases, since before you were born. And Pike could be telling you the most sensible thing. He could be telling you your house was on fire, but you would not believe him because you see him as stupid boy. And the way you see him is a frame. A frame is culture in shorthand. It's the mental shortcuts we all use about other people and other organisations. So it's the way primary care sees secondary care. It's the way primary care sees the Department of Health and Social Care, or NHS England and Improvement, and vice versa. How the NHS sees local government and vice versa. It's how you see people in the other departments. They are the good guys. They are the bad guys. They are the blockers. Often based in metaphors, as I've said, you know, some people see others as sort of strange woodland creatures or sort of monsters or dragons. Often about values, deeply held values, say that we are the good people. This is how we are. You know, we want to help patients. They are the managerial apparatchiks who never think about patients. They're prime for association. So once you've got someone in a frame, that's how you'll see them. That is how you will see everything that they say. And frames take precedence over facts and evidence and rationality all the time. So if you look at the US at the moment, the people who believe that the idea that the election was stolen, they are not going to be persuaded by any amount of evidence to the contrary. And they can be continuously reinforced, so they become hard to shift. But the great thing is that they are not immutable. They can shift. Once they shift, people turn on a dime, and the previously unthinkable becomes the new common sense. So reframing is a great way for you to get your message across and your points across in ways that get people to change their thinking. And it might sound terribly fluffy, but it absolutely matters. If our frames don't actually match, or if what we're saying doesn't actually match the frames that people have already, or we're using people who are the wrong messengers, we will not influence. So if we just say, no, it isn't, all you'll do is reinforce the original frames. So when Dido Harding was in front of the Health and Social Care Select Committee in mid-September, saying something like, I strongly refute that the test and trace system is a failure, all you hear is failure. That's the word that kind of sticks in your mind. So you're not just denying here. What you're looking to do is to move the frame onto your territory, onto the message that you want to give. So it is really worthwhile thinking about the frames that are in play. How are you seeing other people? How are they seeing you in advance? And therefore, what messages do you want to give? How do you want to tailor them? And who might be your messengers? It might be that the message is better coming from a GP, coming from a district nurse, coming from a counsellor. So it's really worth thinking about this. And in case you think this is a theoretical exercise, this is an example not from primary care but from homelessness, but the point still stands. So council in Bournemouth saw homelessness as a public nuisance, so they did things like putting bars on benches, and someone from Bournemouth told me this, they played loud music in the bus station overnight to dissuade rough sleepers from staying there. About 100 miles down the coast, Adrian Worthing, same political makeup of the council, moved from seeing homelessness as public nuisance. Over time, their frame shifted to seeing homelessness as a public health issue. And because of that, every councillor who had responsibility for planning voted for what had been a nurse's home to become a hostel for homeless people. And local MPs, Conservative MPs, stood up and defended it in the House of Commons. So this can make an absolute difference to what happens on the ground. It can make a real difference to patients. It can make a real difference to practice. And again, I'm not going to play this, but when you get the slides, have a look at this. This is reframing in relation to health inequalities, saying absolutely, this is for everyone. It is really worth thinking about what the frames are that you want to actually pass on. So I'm going to just move to a summary. First thing is, if you're leading through COVID, you're likely to be leading in complexity. And when you're doing that, you're likely to get pushback and resistance of one kind or another. And we've talked about some of them here. What you need to do, therefore, is to adapt your leadership here using systems leadership approaches. We've talked about common purpose and relationships and trust above all. So having those meetings that don't have an agenda, don't miss that step out, build the trust first of all. There are systems leadership behaviours that really help here, whether it's getting off the dance floor and onto the balcony, or seeding leadership, or supporting and enabling other people. And sometimes you've got to choose your battles, but make a start. Don't wait for everything to be perfect. Start anywhere, follow it everywhere. There are lots of tools that you can, and techniques that you can use, particularly around narratives and reframing. And keep going, because it really is possible to see change happen and to lead people through what is a really, really difficult time. So I'm going to stop there, and really I'm going to sort of come back to you. I know that there is a sort of a half-hour discussion session after this, but I just wonder, I'm going to come back to you now. Any last sort of thoughts or comments or questions? So, right. Any more for any more? If that's the case, then I'm going to hand back to Vijay and Jacqueline, just to sort of finish the session and then move people on to the discussion.
So again, Debbie, thank you so much for that session. That was absolutely wonderful and inspiring. I've heard it before. Every time I listen to it, I learn so much each time. So thank you again. And I encourage people perhaps to go back and listen over it again, because actually there is so much in that. And you'll just pick up new things every time. And this stuff really works. When I first heard it, I've started using it, and it really, really works. The public narrative is brilliant. I mean, it works for lectures, presentations, and meetings, and interviews, and any environment. It just works every time. It's amazing. So give it a go. Yeah. I encourage you. And that's, people get a bit confused about systems leadership, I suppose, Debbie. It's a word, it's a jargon word. What does it actually mean? But the way you've distilled that down actually is really important, because the bottom line is common purpose, as you said, and it's a way of influencing and bringing about change.
Absolutely.
And the way you do that is through relationships and trust. I mean,
yeah, and you're already doing it in so many of you are already doing it in so many ways.
Yeah. The problem I think doctors often have in primary care is problem solving. We try to get into solutions too quickly.
Yeah.
I think we sometimes need to unlearn that about solving everyone else's problems, because we clearly can't.
And you want to, though, because that's what you're there.
That's what we do. We're trained.
Yes, yeah.
Our job.
Absolutely.
Yeah. So again, I can't thank you enough.
Oh, my pleasure. My pleasure.
Jackie, did you want to say anything?
Thank you, Debbie. No, thank you, Debbie. I just echo everything that VJ has said, and hopefully you'll just stay on if people do want to follow up the discussion. It was something that people came back when we put it out there and said, how would you like to end the session? And it was just about, you know, and I know we've already talked about it, and Romy's given a really good example around the CCG and the meetings that we're having, which was just about how you've overcome challenges through COVID in your practice and sharing that good practice. So it's just an open discussion, and as I said, Romy, yours was a really lovely example. So just an opportunity to discuss that and follow on from the insightful presentation. Thank you, Debbie.
Thank you.
Good. I think
Yeah.
you know, don't lose this momentum. Just think of one thing you're going to do differently tomorrow or at your next meeting. It's as, you know, it's as immediate as that.
Yeah, small things, small doable, practical things.
Small doable things.
Don't need to do anything vast.
No. And if you just want to take your cameras off and your mute off and just jump into the conversation.
Rob, did you?
Yeah, no, I think yes, VJ said about trying something out. I think also, as much as anything as well, is some of it is about noticing things and being just, I mean, that's a step in itself, in just actually just being curious as to what is going on and why it does feel uncomfortable, or why it isn't working, or what the issue is. So actually just being curious.
Yeah.
And reflecting.
And not letting it slide under the carpet either. You know, following that. Yeah. If it feels like it's not working, it probably isn't.
Any other comments? Anything else anyone wants to chip in?
Yeah, I think so. My main comment is, I'm looking at it from the context of COVID and how we managed it in our little practice. I think the first thing I will observe is that actually preparation for COVID starts well before the crisis. And what I'm meaning to, what I really want to talk about is about organizational culture. And I'll give you an example of what we've done. About 2 years ago, I went into an office in NHS England, you know, at Fulbourn, at the, you know, medical directorate office. And they had a large board, almost massive board on the wall, where they have their weekly informal meeting, who is in, how's everybody, what's happening, very informal, no agenda on it. And so I literally picked that and we implemented that in our practice, actually. So we sit down, who's done well last week, how's everyone, you know, how we're going to cope this week, any problems. But it's a quick 15-minute informal chat. Really, how are things, asking about people, kids going to school. And we've had that for quite a while, which had kind of helped build the team and everyone, and we get anyone to chair it, you know, on a, you know, on the day. It could be a receptionist, HCA nurse. So what I'm saying, that we build our culture, which we found extremely helpful when COVID came, because already we had a platform and actually where to have that conversation. So it was actually a continuation of that conversation. People were extremely scared. People were able to open up, some scared for themselves, some scared for their children, parents, and things like that. So I think that it just underlies. I found that was one of the single most important things that helped us as a practice to deal with. So I was quite, you know, pleased when I heard Romy talking about actually speaking with the CCG, having a conversation with no agenda. I think is the most underrated thing in the NHS. You know, just talk, and it's about the system and people and finding out how other people are, and also building that relationship even within the organization. You know, we talk about it being the currency of trust. Once you really need those conversations going on. So that's
Yeah.
I think you prepare not just for that crisis, but actually well ahead.
Yeah.
I'm hoping that this will give opportunity for people. I'm sure lots of people have done lots of things to continue some of those things they've done to build the teams during COVID and carry on even after the crisis.
Yeah.
Sorry.
Yeah, no, I think just to add to that, I think the key at the moment in a way is that I think either places like Mark had things in place that helped that kind of challenge, but also some places came to the problem and actually found solutions along the way which were new. And in some respects it's the slide that you kind of one of the slides resonates about not returning to the old normal, because actually there will not be an old normal. No. And actually what is normal, and actually this is, you know, you've gone through a change process which was imposed, but you've gone through it and you've come out at the other end, and actually some good things have come out of it. So almost not being as uncomfortable about change and transition, because we are, whatever one says, is how we deliver care going forward is continuing to evolve. It always has done, but it definitely feels in a very pivotal moment at the moment.
Yeah. And it's worth just following up on that transitions point, Robert. I don't know how many of you have come across William Bridges' work at all. He's leading through transitions. He is really worth looking at. And he says, you know, it's not the changes necessarily that do you in, it's the transitions and sort of knowing where you are and marking the endings. He said you can be in kind of an end state, in a kind of neutral zone, and then in the kind of new beginning. And I feel at the moment we're in this kind of neutral zone. So there's something about supporting people where they've come from out of one old normal. They're not in whatever the new is going to be yet, but actually we need to do this, to be in this holding pattern. And how do we support people to say, actually, yeah, I can be in this place for a while at least.
I think one of the nicest phrases that I've heard through COVID coming out has been the flattening hierarchy. And people talking about being comfortable, about, you know, being able to put things on the table and discuss things openly without that sense of hierarchy has been something really positive to come out.
Yeah. And people being often redeployed into new groups where their former banding, you know, wasn't the kind of constrictor that it has been. So many people in the NHS that I work with, I can't do that because I'm just, and there's always the just. I can't do that because I'm just a band, whatever it is, and it doesn't matter. They can be really senior, but they're never quite senior enough.
Yeah.
And I just want to pick up on Mark's point as well about not waiting until you get the crisis. Build the relationships and the trust in advance. Build your culture in advance.
Yeah. Just throwing in a question really for us in the Leadership Academy as we're planning and, you know, thinking about programs that we have been running slightly differently. What anybody's got thoughts on the leadership development needs are at the moment in time? Has anyone got any thoughts around that?
Can I? Yeah. In terms of needs, I would say generally this has highlighted even more the need for leadership. It has also, the people who said, I'm not a leader in the sense of it, have now realized that they are taking responsibilities and it's okay to get on and do it. So this is in the context of, more people would realize, and I think this is really highlighted the need for kind of more leadership development. That's my feeling.
Yeah.
I think the challenge going forward again is about, so there's the need there. How do we, or looking at the Leadership Academy, how does the Leadership Academy meet that need of the increasing need? What type is it that, and how is it best delivered? And I was just thinking, actually, the collaborative is a good model, but is it a one size fits all? And there are two things now in terms of the difficulty and the challenge of being physically delivering, because I've always found most of the programs I've been on or facilitated on, it's the networking, the interaction, and the peer learning that is as much as good as the content and the things. You get people, they inspire you, but then you chat with. And how do we bring that on the table? I'm not sure, really. So those are my thoughts.
Yeah. No, I agree. It's the opportunity that people get to come together, which is very limited these days, isn't it? Before COVID, of of networking and learning from each other, that is often really important on sessions. Okay.
And I think having those meetings without agendas sometimes, there's how are you meeting and just coming together as a group. Just through that, you're developing your own leadership.
Yeah, absolutely. Yeah.
And Kate's put in something about resilience as well. Yeah, which is not the same as just sucking up, any amount of nonsense that's thrown at you.
Yeah, that's a key thing, Kate, that's been coming up actually. So thank you for that. Yeah, a few people have come forward with that. It's a really big need at the moment.
I mean, so I need to be honest and say tomorrow's practice/CCG call that I have does have an agenda, but I think from today I will make it a point. I am chairing the meeting to make sure that the topics that I'm bringing up is something that they've all raised, so we know it needs to be discussed. But to not just have my CCG hat planted firmly on, but to look at it from the provider side as well, because I always say, we are commissioners, but we need to be responsible commissioners. We need to listen to our providers, see what their issues and barriers are, and be able to address them so that they can achieve what we need them to, so that we can then report that back to NHS England. So it's a domino effect, isn't it?
Yeah.
I'll make sure to have that overall broader view of the issues that we're raising tomorrow.
Thank you.
So, Romy, I think just to add to that, I'm not sure it's not that having the agenda it's in itself bad, but I suppose it's having enough time and space. We've all been to meetings where it's a packed agenda, 23 items, we're just rushing through. There's really no space in between for just kind of ordinary conversations. I think it's just a question of designing the agenda in such a way that there's always free space. Even though we're not meeting physically now, it's more important to have a conversation like this, actually, that it's open-ended and really just, just trying to get a sense of and gauge what is happening. And I like, one of the slides Debbie showed was about who needs to be in that room. I think I always ask two questions. One is who else needs to be in this room or this conversation? But the second thing in any meeting is actually as important as what is not being said. And I think, it's really, really important to listen to what is not being said. When there is an obvious issue there and nobody is talking about it, you go for a meeting about COVID and nobody is talking about their fears, their anxieties, then you gauge it, what's wrong, what's going on here. And it often happens. So I think those are two things and actually for us to kind of stimulate that conversation and actually listen very well.
Yeah, no, agree.
And I think that just leads on to also, Mark, to the broader comments you were making about when we're thinking about leadership, is that we're all leaders, and it's those that it's trying to reach people across a wider breadth of the community to feel they can have that level of conversation, and not that it's some mystique or it's some kind of specialist requirement, etc., etc. So in other words, in a way, it needs to broaden somehow. So therefore then that conversation in that kind of collaborative way of working becomes the norm. And I think that's another factor for me in terms of how to broaden it out.
Yeah, I encourage you just to try stuff out and see what happens, and some of it will work and some of it won't, but overall you'll learn.
Yeah, great, thank you. Is there anything anyone wants to add? VJ, do you want to add anything?
Nothing more for me. Rob's got his hand up.
No, I haven't. Put it down.
There's a new selection of T-shirts coming out with things like, is that a legacy hand?
You're on mute.
Okay, I'm going to have several. Yeah, I'm going to have several of those for Christmas. Clearly.
Yeah, so am I.
It's something about the years that have gone by, perhaps. I don't know. No.
Oh, brilliant, thank you. Well, just remains to say again, thank you, Debbie, thank you everyone for attending, thank you, VJ, for joining us. It's lovely to see you.
Yep.
And it's been a really inspiring session. As I said, I'll make sure we send the slides out and the link, and an evaluation will follow tomorrow, and then we'll send out some other links as well around support, the looking after you too for the primary care, and some other support and coaching support that we've got coming up for everybody to do what we can and help support people along the way. So thank you, Debbie. We need an applause.